I'm Carol Haraden. I'm a vice president at the Institute for Healthcare Improvement, and I work with Jason on this project in Scotland, so we'll talk more about that.
So the good or bad news is that this is the session that is being transmitted around the world, now, live. Okay, welcome aboard. So that means a number of logistical issues for us and for you. It means that we have to stand relatively still and not wander as much as we would like. It means that everything that is said has to be microphoned. Otherwise, the 25,000 people around the world who are watching, and one of whom is my mother, won't be able to hear anything. So no swearing. No. Okay. So if you're going to speak, we're going to bring a microphone to you. The cameras are behind you, so nobody will see your faces. So if you're here illegally for some reason, then nobody's actually going to know.
Unless you say who you are and what organisation you're from.
So if you have smuggled out of the UK to get to the Netherlands, that may not be wise to ask a question. But so just to give you the idea that the logistics may be slightly more challenging than there's a guy at the back switching between cameras and switching between sound. So we'll do our best to cope with that.
So one last thing, when you ask questions, we need to have you asking them into a mic. So you'll have to wait till we get to you before you ask your question. Okay? Does that make sense? You understand? Great.
And there's going to be a couple of exercises. Now, exercises remotely are going to be very difficult. So those of you watching on the TV, I can feel my phone vibrating in my pocket. So clearly there are people watching because they're trying to put me off. And if we're going to try and do those exercises remotely, but there's no way they can communicate in, unfortunately. So hopefully they'll do the things that we're going to do with you, and we'll get there. Okay, yeah. So there we are. So let's just take a moment to work out who we are. So I'm from Scotland, Carol's from America, but kind of Scottish. So
where else? For 4 years.
Where else do we have? Put your hand up if you're Dutch. Terrific.
Great.
Put your hand up if you're from the US. Okay. If you're from Canada. There's always a couple of Canadians, see? And I recognised at least one of them. If you're from other European countries, so where do we have?
France, Germany, Spain.
From the UK? From England, probably. Yeah, England. I told the lady at the door to not let any English people in, and she's clearly
Luton
not.
and Dunstable.
So,
an old colleague.
Where else in Europe? Finland.
Irish but working in England.
Okay. Irish but working in England.
Where else?
Norway.
Sweden, Norway. There's a Dane right at the back. I see a Dane.
Yep.
From Northern Ireland.
Luxembourg. Great.
That's half the population by you coming here.
They closed the hospital.
Who's in charge of the hospital while you're here? Anywhere else? So let's go to another continent. Let's go to Africa. There are a number of Africans here. So we have, from which countries, guys?
Ghana.
From Ghana? Ghana. Let's see, Ghana's empty as well. Namibia.
Excellent. Yes?
South Africa. Oh, yes, I didn't see you, Kathy. Hi. Anywhere else we haven't been? Let's go further. Let's go New Zealand, Australia.
Singapore.
So.
Okay, I see my colleague from Singapore.
Scottish but living in Australia.
Okay.
There were some hands over here. Australia. Great. Australia. And some Singapore.
Yep. Got a
Great.
colleague.
Have we got everybody? Anybody else? Middle East. Let's go to the Middle East. Yeah, I see. Lebanon.
I'm from Palestine, but work in the UK.
Okay. Bahrain. Syria. What? We should add a big map, shouldn't we? It's fantastic. Just what a great place. Thank you so much for coming. So, have we done everybody? I don't want to offend any particular. I see this is a danger, isn't it? I'm going to run out. There's going to be one continent I forget.
I think it's a very important country, Afghanistan.
Afghanistan. It is important. You have a lot of people here as well. I spoke to Kathy and some very important people here. Afghanistan.
Excellent. Great.
Japan.
Oh.
There we are. From Haiti.
Excellent.
Afghanistan. Anybody else? Not. Have we been everywhere else? But I don't want an international incident.
That's right. We cause enough of those.
Yes, indeed. So here's roughly what we're going to do. I'm going to set a little bit of context first about the Scottish challenge and what we were faced with 3.5 years ago. and the aims which we set. We're then going to ask you in 2s and 3s to try and decide what we should have done. What should we have done particularly around capacity and capability? There are a number of talks Carol and I can do around this. We could just show you results. We could just show you. But we're going to concentrate particularly on capacity and capability building for a nation. So we want you to decide, in our position, roughly what would you have done in 2s and 3s. Then we're going to tell you what we did. Now, it may be wrong, it may be right, but tough. It's what we did. Then we're going to give you an illustration of how that worked, and then hopefully at the end we'll have some time for you to work again, perhaps in countries, perhaps with strangers, to work on capability, capacity in your world. And Carol's going to lead that at the end around a production planning process that might help you begin to think about how you could design for whatever your context is, even if it's a small clinic, if it's a nation, whatever your world is based on, hopefully some errors that we've made. So that's the order in which we're going to function, and we're going to be finished by 12 o'clock. So let me just set you a tiny bit of context. This is Scotland. It's the small country just above England. You'll know that any Italians in the room? No? You'll know that there we are. So you'll know when the Romans invaded, they got to the top of England, and then we beat them. The Scots stopped them at Hadrian's Wall. And we built the Romans actually built the wall to keep the Scottish people out. But the Romans could get no further. So we're the bit above the wall. And this is Scotland. The shaded areas are our delivery systems. We have 14 delivery systems delivering the healthcare, health and social care in an integrated way, primary, secondary, etc. We have each of these boards has a board of governors that look after them, that deliver the healthcare within that context. There are 2 which warrant special mention, and that's the 2 that are contained within the little dark line off to the right. There are islands. Now, if they were to scale, the islands would be somewhere on the ceiling because they're so far away. They're closer to Norway than they are to Edinburgh, in fact. And the people are a little... I better be careful in case any of them are watching. They're odd. No, they're not. I'm joking. They're wonderful people, and we spend quite a lot of time there. But they're small. The communities are small. There's one hospital. There's 25,000 people. It's not a big system. And yet Glasgow is one of the biggest healthcare systems in Europe. It has 51,000 employees. It has a huge budget. It has 7 big acute hospitals. And it is the same. It has a board, a chief executive, and yet the islands have the same thing. So we have 14 delivery boards. And then we have other boards who provide the services to those delivery systems. So we have a quality improvement board, we have an education board, we have an ambulance service, who are universal across the whole country. Does that make sense? And they deliver the out-of-hours care, they deliver the things that we need across all the delivery system. And they are the special boards. Our budget, this is a year old now, £10.5 billion. Somewhat integrated health and social care, not completely. We still have quite a lot of social care provided by a separate system, our local authority system, but a lot of the social care is integrated, and I've already talked to you about the special boards. So just before we talk about the safety programme, I want you to just hear one story about why Carol and I do what we do. Why are we working in this slightly crazy world? This is John. John is a patient in one of our intensive care units. He's a long-term... He's got a chronic lung disease which requires him to be admitted on and off to our critical care, one of our critical care units. He's a wonderful guy, but he's not well. He's pretty sick. He spends a great deal of time in this intensive care unit, and they know him well. One of the interventions in the Scottish Patient Safety Programme is daily goals in intensive care, and many of you are probably working in that area. Daily goals usually based on clinical requirements. What's the oxygen saturation? When are we going to wean them from the ventilator? When are we going to do clinical things? And we write them down, and that's a good thing. And the doctors and the nurses on the ward round decide what the goals are, and then they move to the next day and see if they met them. One of our critical care charge nurses, who I thought might be here, I don't see him. One of our critical care we've got somebody from the critical care in Scotland, but not the right charge nurse on this occasion. But he introduced, as part of his project for the Safety Programme Fellowship, he introduced patient and family goals, where rather than just clinical goals, the patients and the families got to write goals. And lo and behold, they didn't write anything about oxygen saturation. you may be surprised to hear. They wrote about, I want to eat my favourite yoghurt. I would like to see my grandchildren. I would like to make sure my grandmother knows I'm well because she can't get out of the house. Simple family and patient things. Now, this guy had a particular patient and family daily goal which he wanted, and it caused us some challenges. He wanted to see his dog. So what do? Infection control, you don't tell them. At all. So you have to avoid infection control. Now, you can either bring the dog to intensive care, that's maybe not going to happen, or take him to the dog in some way. So Forth Valley, the doctors and nurses in Forth Valley decided to do just that. They took him to the front door on a portable ventilator and introduced him to his dog, who he hadn't seen for 6 weeks. It's just a really simple story. It's not to do with his antibiotics. It's not to do with his ventilation. It's to do with him as a human being. It's about his life rather than him being patient 1 on ventilator 2. It's about him being a human being, just like you and I. And now, the infection control people are assured that we chlorhexidined him from top to bottom before we put him back in his bed. We showered him no, I'm joking. So that he was clean when he went back to intensive care. But I hope you get the idea that we're going to talk now about what the Scottish Patient Safety Programme has done. We'll show you some results later on. I want you to bear in mind that the whole purpose of the capacity and capability building is for joy. It's about the individual patients and the individual people who make up that patient's life. The family, the kids, the parents, the grandmothers, and the friends of these individuals. And that's why we've spent some time thinking about capacity and capability. So here's the challenge. This is the Scottish Patient Safety Programme aims. 3.5 years ago, in January 2008, we decided we want to reduce all-cause inpatient mortality by 15%. All-cause inpatient mortality by 15%. We want to reduce adverse events by 30%, and then we want to do some so within that, there are some aims for critical care, for the ward, and you can see them. But I want you to concentrate on the 2 principal aims, the adverse event aim and the mortality aim. We decided that we would do that in 5 work areas: critical care, the ward, medicines, theatres, and leadership. And these are some of the interventions which we chose to do. This isn't them all. It's just a selection of some of the interventions we chose to do. So here's your challenge. What do? We have 14 boards. We have 151,000 employees. We have a budget of £10 billion. And we have 14 boards who provide that care. So we have 14 chief executives. I have 14 medical directors. I have 14 nurse directors, plus the special boards who provide the services, remember, across the system. So we have a chief executive of the education thing, a chief executive. And we have IHI. So we have a partnership with the global organisation that leads this work around the world. So where do we start? So I'd like you just to talk for 5 minutes wherever you're sitting. Just turn to a neighbour or in a little group of 3 or 4, however you want to do it. Don't be by yourself. So try and find somebody to talk to.
You're not talking to yourself.
And don't start talking to yourself. and try and decide very generically, just at macro scale, what should we do? How should we build the capability and capacity to do this, to deliver for our health minister and for our population a 15% reduction in mortality? If you're watching on the cameras, I need you to do that. If you're by yourself, you're going to have to just scribble it on a piece of paper. If you're in a little group, then do exactly that as well. Maybe you could spend some time doing that. And then we'll call you back together. We'll take a little bit of feedback. And then Carol's then going to start with illustrating to you what we actually did, whether that's the right answer or not. So 5 minutes. Go ahead.
I think that's dead. We'll need it to ask them questions, I suppose.
Okay. Can I just bring you back together? I realise this room is so clever that it could almost certainly spend the whole of the next hour on that single problem. And with hindsight, we should probably have done this 3.5 years ago and got you to design it for us, and then we might have been more successful. But here we are. So does anybody want to just give us a little insight into what you decided we should do? We have 5 minutes before we go to Carol with the solution. So.
I am very fan of the strategic planning and the balanced scorecard, and I would put my objectives divided into 4 axes, which are the quality, the patient satisfaction, the human resources, and the finance. And then I would put goals for our NHS boards and communicate those goals to them, and they have to put their objectives and their measurement tools and achieve the goals.
So, are you fixed in Lebanon? You wouldn't like to come to Scotland, no, to work? Wait.
You need resources to make this happen.
Oh boy.
Anybody else? Here we are.
I think I'm Dr. Nadra from Afghanistan. I think if I will be the head of this hospital, I will ask from this 14 board, head of 14 board, to have a meeting and look what's the aim, how is the responsibility of each board, and ask them to go and talk with your relevant colleagues in a board and come with a strategic plan, set an objective and goal, and all will be communicated about our aim, objective and goals, and will together to improve, find the gap, like a SWOT analysis. What's our weakness, what is our strengthening, what's our opportunity, and after that we see that how capacity need, how equipment need, how supply, and after that we manage all them. We will go by commitment and for sure that we achieve our goal.
So we're going to go to the executives and we're going to ask them to set individual goals. So we'll have 2 more and then we'll need to tell you actually what we did, which is, I'm now thinking is a bit rubbish.
No, it isn't.
It's Norway here. I think you have a problem in managing the risk because you're going to deal with objective challenges. And if you do this process in every board, you have to do the process times 14. So I think you have to have a national team to establish the critical limits and to establish the risk factors within every field. Yeah. And then, of course, there should be strict leadership through the board structure.
So that's interesting. You think we should have a national thing that sets some boundaries and then let individual boards work out how that should be done in their context? That might be what we did.
I'm Minerva Kroon from Helsinki. I work with development in primary care. So I think that we were talking about more practical matters, how to get the miracle to happen.
Yeah.
You would need a network of facilitators and opinion leaders and start with like a collaborative breakthrough, that you start somewhere with the early adopters to make changes, that you, after maybe a book review, you see that this could work. Then you have their experiences that, okay, this worked, this didn't work, and that you can see they got this goal. I'm sure you can do something also. But to have the facilitators have some kind of education for improvement work, what methods work, so that you get everybody on the floor level to communicate.
I didn't speak to you beforehand, but you think we should run a collaborative and we should bring the early adopters together, and then we should have people in the boards facilitating the changes.
Wow.
That sounds like a good idea. So Carol's going to talk through what we did.
Okay. So here's our driver diagram. How many of you know what a driver diagram is? Okay. So a driver diagram is a depiction of your theory. So I can hear, as you're talking, your theories. Your theory is that people have to have an opportunity to try it. They have to learn how to improve. Your theory is it's really more governed by goals and objectives, right? So you've got two very different theories, right? So this is our theory. Our theory was to improve the safety in healthcare services in Scotland, we had to do 5 critical things. And you notice they are not, see the third one down, deliver the program? That's 1. Everyone thinks it's about the program. But if you're working at a national level, you have to seat that program within the socio-political boundaries of what's going on in that country. You just don't walk in and say, hey, we're here, don't know what else you're doing, don't really care, we're going to be doing the Scottish Patient Safety Program. So we had to work strongly with government. So the primary drivers are the big ticket items, and the secondary drivers are what we did to make them happen. So we had to build a sustainable infrastructure for improvement. Because you want this thing to be sustained. You don't want it to be a project. We had to align our goals with the national goals. So you don't walk in and say, guess what, we're going to reduce C. difficile, Clostridium difficile infections. Now, we have a whole national body called Health Protection Scotland, a special board, who, by the way, actually existed before we did. And it turns out, gee, they have an interest in infection too. So we just didn't walk in and say, well, not really knowing what you're doing, we're going to go ahead and do this. In the setup phase of this program, we got out there and we influenced a ton of people, and they influenced us. So we spent a lot of time talking and negotiating. So we had to give a little, we might say, I'm not crazy about that definition, but it's good enough, okay? I'm not going to insist that everything be done just our way, because that's not sustainable. The program over time dissipates, but HPS stays. Health Protection Scotland stays. That's the sustainable infrastructure. So we have to work together to make that work. Boards endorse. So boards are those geopolitical bodies, the 14 delivery boards, and they had to endorse safety as a key priority, because in Scotland, this was announced as a national you must do. This wasn't a campaign, come if you want. This was you're going to do this. So you don't necessarily have the hearts and minds of everybody. You can't assume you do. Some people were like, yeah, best thing since sliced bread. The other people said, all right, we'll come because you have to. And so you have to win those people over. Some people are already won over. Then there's a great unwashed in the center who are skeptical, and should be, by the way, because they've been through 100 things before. And then there's the people who say, I'm coming, but there's not a prayer. I'm really participating. Okay? And so your job is to try to figure that out and win them over, right? And the only thing that does that is good work, to be honest. Nothing wins clinicians over except results. I mean, they like the excitement and they like doing things that seem to make a difference, but in the end, it's got to deliver, or else you lose people, and you should. So this notion of a driver diagram is an important one, I think. We use them at the Institute all the time, and we use them in Scotland all the time now. You don't see almost any program now that doesn't have a driver diagram. And the interesting thing is it does lay out your theory. And people can look at that and say, boy, I think you're missing something. Or, really, why did you choose that? So it's an interesting way to have that conversation, because this is the guts of our program. And only one is actually delivering the program we're going to talk a lot about. Okay? Lots of other work going on. Okay, so I'm going to talk a little bit about that third piece called Deliver the Program. Okay, we're going to spend some time talking about that here today. So early on, the Scottish government put out an RFP, request for proposals. We applied, and we won the proposal. And so you come in as technically a contractor. But if you are going to work to change a country, you cannot be outside the circle. You've got to be inside. So you have to agree right from the start, we're going to be one team. It's not going to be the Scottish team and the IHI team. It's going to be the SPSP team, and we're going to act, think, and work like a team. And we established that 4 years ago. That was very important to us. Okay. So do we have individual interests sometimes? Yes. But we try to always focus them on the program, not on what we individually want. Okay. So it's been really, really important to do that. Really important to do that for us. We segment the hospitals. At the start, we thought we'll have a different strategy for large academic centers and a strategy for middle-sized, maybe a strategy for rural. And it turns out actually wasn't useful to us. Wasn't useful. It got way too complicated. And so we pretty much said, let's have one strategy, one set of changes, and if you come to me and you say, I'm different, I'm X, we listen to that and we decide what should we do about that. Now, how many of you have hospitals who say at every turn we're different? Right. So we knew that was going to happen, and so we just plodded on. We said, yes, you are. You're very special. And now let's get on with the program. Yes. We love your specialness. We're going to now, let's get on with the program. And we actually got past most of that. We got past most of that. You have to focus on the patients aren't different. They really aren't. But the resources can be quite different in a little island board up in the Shetlands than in Glasgow. So you have to think about that. You have to think about those patients are shipped when they're really sick. So you're starting to talk about ventilators and ventilator-acquired pneumonia. Well, you put a patient on a vent in the Shetlands just long enough to get the helicopter from the Highlands to come pick them up. That's not an issue for them. So you have to think about what are issues when you initiate ventilation is their biggest issue, right? Getting them on the vent quick enough, thinking about how to manage that. So very, very different. We customized for those things. And we continue to do that, honestly. We're always learning. And I guess I'd have to say, that's true for every program, but it's especially true for one where you're entering somebody else's country or region or state, as it would be in the United States. You have to come in with enormous curiosity and be willing to be influenced. Be willing to be influenced. And that's something we have to ask ourselves. When we find we're pushing back hard on an idea, I have to say, and sometimes I say to my colleagues, are you willing to be influenced? And they say no. This is the bottom line for me. That's good to know. We need to take a different tack now. You know? So the ability to be influenced, the ability to listen and go beyond assumptions is very, very important, particularly if you're a guest in another country. I ended up moving to Scotland for 3 years. I was a year in London and 3 years in Scotland. I just moved back a couple weeks ago because I needed to be in the country that we were attempting to fix. Okay, it just felt important to do that. Plus, it saved me a whole lot of travel. Yikes. So I have a metric for my quality of life. It's how many different beds did I sleep in this week? And it's not recreation. It's all about being tired. So we developed strong support for our program managers. We'll talk a little bit about that. We asked every health board to have a program manager who led the program in their area. Okay, they are the linchpin. For any of you who are going to do this work, I just am going to say, you have to have on-the-ground support. So I've got a colleague of mine, Jakob, in the back from Denmark, and we're doing some of this work in Denmark. I don't know, do we have any program managers here from the Danish hospitals? We're working in 5, and they have very strong program managers. They have mostly physicians. Jakob, of the 5, how many? 3? 3 are physicians. So very different model than we had, but it didn't matter. They have to have really, really strong skills, and we had to develop a strategy to support them. Because we thought they were interesting, and they'd come to the learning session, and they'd get on the calls when we were talking to critical care. But it turns out they needed their own calls. They needed their own meetings to really build their skills, because they are orchestrating this whole thing in their organization. We had a chief financial officer strategy, which I'd say we've done all right with. I wouldn't say it's the... I'd spend an hour talking with you about it. I could spend 15 minutes. The interesting thing in a country the size of Scotland is you have once a month, all the what we call the high C's get together. Monthly, every CEO, every hospital, or every health board is in the room together. The CFOs are together. So you can go to one place and get to all of them, which is really remarkable. I would say it's not the easiest thing to get on their agenda all the time, but we do it because Jason sits on that group, so we do it routinely in small doses. The chief financial officer, twice we've done, we've gone to their meetings and done an hour, hour and a half, 2 hours with them, talking about the cost of quality, the trade-offs, the issues, the concerns. And so in some boards, they're enormously involved. But we thought we would try very, very hard to influence them. We needed serious in-country support for boards. So IHI brought a lot of faculty over to start with. But we said those faculty have to be matched with Scots. They have to be matched with Scots because we have to start building capacity ASAP. So you can bring the experts over, but they're experts in improvement. We have plenty of clinical experts in every country. You have an expert intensivist. You have an expert surgeon. They're just not expert in improvement. So it's our job to teach them that piece. You know, I don't need to teach a surgeon why you give DVT prophylaxis or how to do that. I have to teach him how to improve the system of work he's working in so that he can make that happen routinely and all the time. That's the piece. So thinking about what do those docs need, they do not need a lecture on clinical changes. They do need a lot of work in understanding improvement. Okay. So we spent a lot of time building that. And there's an in-country team. There's a SPSP in-country team, of which Jason is a part. We have a national facilitator, Roz Gray, who is head of the internal program. Jason looks at quality and safety at a larger level. Roz runs the program. We have regional facilitators who own regions. And I guess the other thing is, we accept any and all invitations, as small as they are. So at first, boards invited us a little bit. And then we get pretty much deluged with, we're having an in-service day, could you come? We're having a Scottish Patient Safety Day in the Highlands, can you come? And we honor all of those. So we'd put them out and say, who can go? So we try to honor every request just to get out there, promote the program, and teach improvement constantly. I think our most interesting one was this notion of everybody in the tent. As soon as we started this program, primary care said, what about us? This acute care, what about us? Pediatrics said, what about us? The cardiologist said, what about us? And now mental health said, what about us? So we had to have a long and hard talk about this internally in our group. And what do you think the trade-offs are? If you say, oh, okay, come on in. Any trade-off there? Yeah, Susanna.
You're having to manage a lot of relationships, so you don't know how much people are picking up as you go along. That would be my first instinct.
So you're building a lot of complexity at the start of a program. So it isn't enough to change all the acute care. You're also taking on lots of other things, right? So we had to really think about that. Our agreement was everybody in the tent. We'd give everybody something to do, but we couldn't run an entire program for everybody. Now, as it turns out, there's a program for everybody at this point. But we invited people into the adult tent and said, okay, your pediatrics, come in and see what of these things you think would apply to you, and we'll give you a little support. That's about all we could do at that point. So I talked a little bit about building the sustainable infrastructure. We did develop our own in-country system, our own in-country culture survey. These are the things we knew would be important over time. We had training programs. We developed those programs inside Scotland. We brought some over from the IHI, but we worked with Scotland. So whenever we brought a program over, for the most part, Scotland would say, we'd like to do that program, so National Education Scotland would come. And they'd say, what can we do How can we do this in our country? You don't want to keep bringing over someone else. You want to do what you can do. Okay. Some things we had to decide. We did the improvement advisor course in Scotland, which is a very how many any improvement advisors here? Yeah, it's an intense course. Goes over 9 months to a year, and it is run by real experts. And I think the decision at this point is they're probably going to buy that program. They're not going to continue to try to do it in-house. But a lot of stuff is done in-house and can be done in-house. So making those decisions is really important. We had to work with other agencies because we aren't the only ones doing improvement. And boy, is that a mistake when you come in. Because we were the new kids on the block, got a lot of press. And meanwhile, there have been people behind us doing hard work for a long time. And if you don't acknowledge that, you become a pariah to those people. And you can't blame them. They're in the back slogging, and you're the new kid up there waving your hands and getting all the accolades. So you have to say, how do we work together? How do we acknowledge the work every other person is doing? How do we build trust with those folks? We're not trying to take the limelight. We're just trying to get this work done, and there has to be some press in order to do that. And not only that, they don't get to do all the work they want to do. They sometimes have to work on really hard stuff like targets, access. I mean, this is tough stuff. Nobody says, "Oh, you're here to work on, the 4-hour wait in A&E. That's great. Welcome. Come on in." Almost never. Where for the most part, I think we had a really good reception because it wasn't a target. It wasn't set as a target. Turns out that's really important. One of the most important things we did with this program is we said to the government, "Look, guys, if you set this up as a target and you look at the data and you measure people against it, we're dead. They're not going to do this." So you have to give us some space and time to create the improvement, and at the end of 5 years you can come back and say, "We gave you 5 years to do this. Okay, now we're going to start looking at your outcomes." But you can't look at folks' outcomes until you properly equip them to do the work. They have to have time to do it. So by setting a target didn't improve anybody's capability to do the work. It just is a target. It's an objective on a page. Didn't mean people were capable of it. So we bought ourselves some time there. And that was really, really critical. And other people didn't have that option. They had to go in and deliver immediately. So trying to understand their struggles and support them was really important. Yeah, true. Whoopsie, sorry.
It's okay. So we're gonna show you some. Now, if this works, we should. Here we go. So we're gonna quickly. I'm gonna just go over the infrastructure, capacity and capability things that we did, and I'm going to do it in 3 fairly quick steps: short, medium, and long term. So what did we do immediately? So this is past. So this I can tell you what we did. Then I'm going to tell you where we're headed. And then I'm going to end just with some results before Carol comes back and leads a little exercise that hopefully will make this contextualised for you. I have to tell you that just when I was sitting there, I looked at my BlackBerry, which is on fire because people are watching. And somebody said, "Be careful, we can hear every single word you say." So when I'm handing the microphone around being cheeky about people, they can hear me in the world. So I need to just be very cautious. Okay? So if I'm cheeky, it's not in my nature. So what did we do for the first 2 years? So we ran a collaborative. So the fundamental mechanism for leading this work was we ran a massive collaborative. We hired a conference centre and we brought 800 people every 4 months initially to learning sessions. So that was the fundamental improvement theory behind what we did. We appointed program managers. We got each of the boards to appoint somebody responsible for the delivery of this program within their context. And you've heard a lot of that from Carol. We did one team. We didn't have IHI people and Scottish people. We had a team. And still, 3.5 years on, every 2 weeks, we have a call, a transatlantic call with the team from America, with the team from Scotland, and we do that together. Now, Carol, unfortunately, is now back in America, so she has to join it very early in the morning. We do it at lunchtime. It's much more civilized for us. We had one team. we went systematically to the executive meetings. The meetings that Carol has illustrated already. The monthly chief execs meeting, the monthly medical directors meeting, the monthly nurse directors meeting, the monthly finance directors meeting. We have an advantage. Population of 5 million people, one health system. So we could put all the chief executives in the one room and get on that agenda. Partly because we had senior buy-in. We had political and senior civil service buy-in that opened those doors to us. We went in and we spoke to them. We also, and there's a couple of these in the room, we did a very specific capacity thing. We isolated out a group of mid-career clinicians, nurses, pharmacists, doctors, physiotherapists, and we gave them a special education experience. And we called that the SPSP Fellowship Programme. And actually, it's been better than I expected. We now have about 30 of them. I was out for dinner with them last night, so they're very sociable as well as very practical. It was good fun. And they have generated their own learning environment now. We provide about 12 residential days over a 9-month period where they come together and they get talks from Unshipping, they get talks from us, they get talks from clever people. They meet at dinner in the evenings. They meet very senior people within our healthcare system that they would find it very difficult to meet otherwise. The chief executives of the system, the senior civil servants. You get the idea. And that's been hugely advantageous. So that's the basics, the short term. So let's think about what we're doing medium term. So what are we doing now and going forward to the end of this first phase? The 5 years, we're not going to have fixed the Scottish healthcare system. We're not all going to disappear after 5 years. But this is the phase we're in now. So what are we doing for the medium term? Well, at the beginning of year 3, we used IHI's expertise and we ran a boards on board event. A very specific thing that IHI do. It's led usually around the world by Jim Reinertsen or Jim Conway. We had Jim Conway, who many of you will know as a very, very big and charismatic leader of a healthcare system in Boston, and then he became a senior fellow and a vice president at IHI. And he came, and we had 150 non-executive directors, so lay directors who run our boards, who provide the accountability and governance for our boards in the one room for 2.5 days. With their executive leaders. And it was transformational. I don't think we could have done it in year 1. I don't think they were ready. But they were ready in year 3. And that was just a few months ago. And it has led to more requests from boards to go and help them than any other single event. But I don't think we could have done it at the beginning. I don't know because I can't relive it. But it strikes me that we couldn't have done it at the beginning.
You did a mini one, no?
Yeah, so we did a little bit. We spent a lot of time with executives. Some people would say we should have spent more time with the non-execs at the beginning. I'm not sure they were ready for it, is my theory. I have no way of going back to do it again. Maybe somebody could try and see if it fails. So the programme, it's not a coincidence I've put the programme managers up again. I don't think there is any more crucial individual to the success of the programme than the individual system leaders that we gave responsibility for it. And actually, I don't think we gave them enough attention in the first 2 years. I don't think we isolated them out and educated them, supported them, got them to support each other as much as we should have. And we're trying to correct that now. We have action learning with them. We have specific things that we do just with the programme managers. And you can see that that makes a difference to outcome. Not just their individual personal development, it actually makes a difference to infection, makes a difference to person-centred care by investing the time and effort in those individual people. And we have a variety of those individuals, and you can rejoice in that complexity of getting who these people are. We spent a lot of time, as Carol said, in local events. It's all very well coming to Glasgow for the big thing, which is crucial. The big thing is empowering. The big thing is you get Don Berwick to come and talk to them. You get the health minister to say, this is the most important thing in the country. That's all really important. No, don't underestimate it. But equally, there's nothing better than small groups in a ward in NHS Fife, one of the boards. So you've got to spend time in local events. We've got a very specific piece of work being led by Shona Cowan, who is in the room somewhere. There she is there. She's in the second row. And Shona is leading for our national education organisation a piece specifically designed to teach QI at every level of our system. And I'm going to show you just a couple of slides in a second of what that looks like. And Shona would be delighted to speak to you at the end about what that looks like. We, again, weren't ready for that at the beginning. But now, 3 years in, we're going to have a curriculum for Scottish clinicians and managers that will look the same. So people will be able to dip in and out of that process. We've linked a lot with the IHI Open School. Carol and I were up very early this morning, unfortunately, speaking to the students across at the student lounge about some of this work. And the Open School in Scotland, particularly in one of our cities, in Dundee, has been hugely successful and beautifully led by Peter Davey and others. So the Open School, if you don't know it, is worth spending some time with. We brought over a very specific entity from IHI, and that was the Improvement Science and Action course and the Improvement Advisor Training course. So effectively, we bought, for lack of a better word, these two courses. Now, when we say we bought them, we didn't just say, please, IHI, come and teach this and then leave. We said, we'd like you to come and teach this, but we'd like you to put Scottish people on it. We'd like you to allow us to put Scottish people on it to learn how to teach it, not just to be receivers of the learning, and to learn how to run it. And IHI are really open to that kind of partnership. IHI like that kind of partnership. And some of the people in this room have done Improvement Advisor training in South Africa, have done it in Ghana, have done... So that's what we did. We ran an Improvement Advisor training course, which we're nearly finished, and we're almost certainly going to run it another couple of times. And each time there'll be more Scottish input, and there'll be more Scottish people doing it. That's the theory. So let me just show you quickly 2 slides on our curriculum, which Shona should really be up the front talking about. But you can see the idea here. There are 3 levels. There are going to be QI leads, QI experts, people who are expert in quality improvement. There's then going to be, and we think probably about 300, but we don't know. It's very theoretical. We think probably about 300 people who we would consider real experts. That will include our fellows. It will include our improvement advisors. It will include people who've been working on other programs long before Carol and I arrived. Then we're going to have practitioners. We think probably initially about 3,000 of them. Not educated to quite the same level, but certainly understanding run charts, understanding leadership, understanding quality, understanding small-scale testing, understanding PDSAs, and understanding lean, some of them. So different things for different settings. And then you can see the big box is all NHS staff. So we expect all NHS staff to understand what the quality movement is, what the agenda is. And then underneath that, some enablers. We're going to have measures for the whole country. We're going to have a knowledge portal, which will be evidence into practice. It will say, if you want to do pressure ulcers, here's the evidence, here's the implementation, and here's results from successful organisations, directing you to contacts that you get the idea. So you can see how that might work. And that curriculum will be delivered in a really innovative, we hope, way. It will begin to take people through this journey of quality improvement. So rather than just bring people in and teach them reliability, bring people in and teach them the model for improvement, which you have to do as elements of this journey, they're going to work in a curriculum that's going to take them through learning objectives depending on their position just now. So they might be a chief executive. They might be a pharmacist in a community. They might be a general practitioner running a rural practice. And each of those will have a specific set of things which will be discussed with them, and their own learning will come out from this package of effectively learning objects. Some of those learning objects will be in-person meetings, some of them will be reading, some of them will be e-learning, some of them will be big meetings, some of it will be CPD type things, and each of those will be made up so that you can be a foundation person, you can be a practitioner, you can be a lead, or you can be at board level. So there'll be a way of dipping into this if you're a non-executive or an executive within your board. So hopefully I've not done that too much injustice really quickly. But Shona will be happy to speak to you. And we'll keep a note for the individual of how they're doing. So we have a system in Scotland of e-portfolios for every clinician. And every clinician will then be able to keep a record of what that CPD is. In the future, maybe that portfolio will become part of a job interview. Maybe it will become something about promotion, about moving within the healthcare system. How are you doing around your quality initiative? You get the idea. And then let me finish, before we give you an exercise again, with our long-term solution. So you've now heard, I hope, something of what we've done short-term the building of the collaborative, the appointing of programme managers, the running of courses, the actual meat of what we actually did to do the safety programme. But the safety programme is not the long-term thing. The long-term thing is to transform the way Scottish healthcare is delivered to the population of Scotland. That is not enough to just do safety and just reduce mortality by 15%. And the long-term Scottish policy solution, which is where I really work, I work for the government, so within the policy environment, is the quality strategy. So in May 2010, we published a nationwide, a national policy document that said, this is the agenda for Scotland. This is it. 3 ambitions: safe, effective, and person-centred. We don't think there's any other country in the world. I've got to be slightly careful with so many countries in the room. We don't think there's any other country in the world that has these as the way the healthcare system works. This is the core of the delivery of the healthcare system. So our minister knows these off by heart. She stands up in the Parliament and she says there will be no avoidable injury or harm in the healthcare the Scottish people receive. That's a very brave thing for an elected politician to do, because every time there's harm, she gets accused of not meeting what she said. Now, clearly she then comes to us to kind of deliver this for her, but you get the idea, and it leads that. And then the way we're going to do that, and I'm just going to briefly discuss the operational piece of how we're going to try and deliver those ambitions. So those are our 3 ambitions. Probably the most important, and the one we're beginning to think about how to do now, is the top one. If we actually did mutually beneficial partnerships between patients, families and those delivering healthcare, I'm not sure we would recognise the healthcare system from what we've got just now. I think it may be the truly transformational one, and we're beginning to think about what that looks like. That doesn't mean I don't think clinicians should wash their hands and we should get rid of infection, which is the no avoidable harm one. But equally, we've got to concentrate on removing the variation for the effective one. At the same time, we've got a productivity and efficiency agenda. We're not going to do anything that costs more money. In fact, we're going to do things that save us money. But we're going to do it with this framework, not with slashing and burning. So how are we delivering that? What's our plan? Well, we have 4 delivery groups. So inevitably in a system of our size, you need some kind of committees. I know it feels odd, but you do need something. So we have a Quality Alliance Board that Carol sits on as an external helper, and I sit on, and chief executives sit on, and the chief executive of the healthcare system chairs it. The Quality Alliance Board, the big thing that will be held responsible for those 3 ambitions by our politicians. Underneath that, we're going to have 4 delivery groups, specifically called delivery groups because they'll have to deliver the ambition: safe, effective, person-centred, and infrastructure. The things that we think are necessary to support those 3 delivery groups. The theory, and remember, we're kind of making it up because we don't really know, because nobody's really done it. But this is what we're trying. In the middle of that is where we think the quality of health and healthcare comes from. That's where we think the core is. So underneath those delivery groups, if you're still with me, so we've got the board at the top. We've then got 4 delivery groups. Each of those delivery groups will then have action groups that will actually do the work, that will go into the boards, that will go into the communities and actually change the way the healthcare is delivered. And this is our first go at what those action groups might look like. Frankly, they're not all up and running. Some of them don't even exist. Some of them do. So you can see in the SAFE column, you can see the Acute Scottish Patient Safety Programme. That's the programme we've been talking to you about. That exists. It's 3.5 years in. It has 18 months to go. It has a numerical aim. It has an infrastructure. You get the idea. Underneath that is the Paediatric Scottish Patient Safety Programme. It's a year old. It has aims. It's younger than the acute programme. We don't yet have the mental health one and the primary care one, but we have documents which are planning them. We have experts working on prototypes. You see how this is beginning to work, I hope. And then we have effective and we have person-centred. And then the really intriguing one for me in particular is because we're trying to build the infrastructure which will then form across all these other elements. And I want to isolate out one of those just specifically to talk to you just for 2 minutes. And that's the Quality Improvement Hub. The Quality Improvement Hub remains relatively theoretical for us, but our theory is that if we can bring together our improvement organisation, our education organisation, and our data organisation into one thing, focused on the quality of patient and family care, we may have hit something special. And we can't combine those organisations, okay? For historical reasons, we can't bring all the organisations together. So we're going to try and virtually bring those together on the same agenda. And the QI Hub is an attempt to do that. And I think it has the potential to be one of the specific answers to a challenge at our country level. I think we require the improvement expertise, the educational expertise, and the data expertise in the one thing. And if I'm not allowed to combine the organisations, then I think we should try and do that virtually in some way. And that's the Quality Improvement Hub, and it's really exciting to see it begin to prototype and develop just now. And you see the others. You see that we're going to have an infrastructure group doing measurement, one doing e-health, one doing comms for the population to tell them this is not only to the workforce, 150,000 people, but also to the broader Scottish population. Education, you get the idea. And then we're going to have high-level measures for the Quality Alliance Board to know if we've done it, to know progress and to see how we're doing. And some of these are very, very high level. Staff experience, care experience, patient experience, HSMR, which I'm going to show you just in a moment, under 75 mortality, you get the idea. We're going to have what we call whole system measures for the whole Scottish healthcare system. And this looks very different from the whole system measures that have existed in Scotland for some time. There isn't a lot on here about waiting times. That doesn't mean we don't think waiting times are important. I don't want to wait for healthcare. I don't want my family to wait for healthcare. But the emphasis is moving. The emphasis is changing to these type of measures. Now, within that context is, very briefly, the efficiency and productivity framework, which we're doing alongside it. This diagram suggests, if you look at it for a moment or two, that we're going to concentrate in the middle. We're going to concentrate in improving quality and reducing costs. We're not allowed to do anything on the left. That's impossible. We're going to try and prevent anything on the right, where you save money but you reduce quality. So closing or sacking just to save money. We're not going to do that. We're going to do as much as we can in the middle of this seesaw, in the middle of this balance, where the quality programmes will be the driver to improve productivity and efficiency. And these are our 6 work streams within that service redesign. So if you just take the acute flow one, which is the 4th one along, you'll begin to see the kind of areas where we're working. So lean the pathways of care, get people out of hospital quicker, same-day surgery rather than overnight surgery, ambulatory care rather than inpatient. Stuff that you are all working on all the time. But we're going to have work streams in each of these. So how are we doing? So forgive me if you give me 5 minutes of results just to show you. So, right, we could have spent an hour and a half on results. You're lucky you're only getting 5 minutes. So how is this safety programme, which has been the kernel of what we're now developing, what has it done? So we have a Scottish hospital standardised mortality rate. It's a special Scottish one. We need special Scottish everything. So it can't be compared with your HSMR. It's a special Scottish HSMR. And the baseline was before the Scottish Patient Safety Programme existed. It was in 2007. And we now have, up until September 2010, results. Mortality takes a little bit of time. People take a little bit of time to die. So it takes a bit of time for it to catch up with reality. So we now know the hospital standardised mortality rate up until September 2010. And this is it. So the first 4 dots are our baseline, and then the rest of the dots are the all-Scotland mortality rate for inpatients within 30 days of being an inpatient, which is different from some HSMRs. Now, there's seasonal variation. The smart ones in the crowd will already have worked out which is summer, which is winter. You can't completely allow in the model for summer and winter. So the simplest way to find the number is to draw a statistical regression line through the dots. So a best fit line. Depends who you're talking to. If you want to really show off, you use first dot, last dot, because then you get a much more dramatic number. But that's a little bit of a lie, really. So the slope of the line is 7%. So about halfway through, we're about 7% reduced mortality. Now, you'll notice I haven't said the Scottish Patient Safety Programme has reduced mortality by 7%, because it hasn't. This is a multifactorial social exercise in all kinds of changes. The Scottish Patient Safety Programme is a small piece of a big picture. There's all kinds of stuff happening. There's people doing C. diff work with antibiotics. There's people doing Scottish audit of surgical mortality, reviewing every single surgical death. There's all kinds of stuff happening here. The Scottish Patient Safety Programme, though, is part of that jigsaw. So I can say, during the time of the Scottish Patient Safety Programme, mortality has fallen in Scotland by 7%. The cause and effect of that is a whole other lecture and a whole other conversation. But that's our HSMR. And then just briefly, let me show you some other numbers. This is our central line infection rate, 74% down in 3 years in every intensive care unit, about 20 intensive care units in Scotland. You maybe saw that in the plenary yesterday morning. Did you see Maureen use that yesterday morning? And then this is our critical care C. diff rate, a 73% reduction. I'm just going to flick through. This is our general ward C. diff rate, a 63% decrease in C. diff. Remember, not as a direct result of the Scottish Patient Safety Programme. Part of the response has been the safety programme, but a lot of other work. This is the surgical checklist in our theatres, a version of the WHO surgical checklist adapted for each individual context that we live in. And then this is on-time antibiotics as a result of doing the checklist. So this is why the checklist isn't magic. The checklist reminds you to do stuff. And everybody knows that if you get your antibiotics on time, you get less infection you get. So that's what we've done. So then, one last slide before I hand you back to Carol, and that's about where we're going next, and we could really do with your help if you're willing to help us. We're already in paediatrics. We're designing primary care and mental health. We don't really know what to do. So we have ideas, but we don't have solutions. And I'm under increasing pressure to add a fifth safety programme, and that's maternity. The midwives won't let me away with it. So there's a lot of pressure and a lot of passion, actually, good passion, to run something in maternity services. Because although some of our acute work applies, so peripheral lines, central lines, there are things that apply within the maternity world, they think they have very specific challenges that we could do something about. And I agree. I think they have. And I think we could learn from some work that I've seen both at this conference and others. I think the Africans could teach us a great deal about maternity care that would be transferable to our context. So that's where we are now in the safety work. And I hope I've given you an image of what we're trying to do across the whole country, broader than safety. And now Carol's going to lead us in a final exercise for the last 15 minutes in what this might mean for your context, a conversation, and then we'll get some feedback from that. Okay, stand it up.
So when we were starting to think about big improvement in capacity and capability building in the country, we asked you, what would you do? And we had to answer that same question. What should we do? Where should we work? How should we work? All of that. So one of the things that I did to try to organize my thinking was to come up with what I called a production plan. Because, and I'll show you what I mean. Whoa. Where are they? I loaded all of this yesterday. Ugh.
So I didn't know you had a different.
No.
So I used the Jason Leitch one. Did you put slides on yesterday?
Mm-hmm.
Okay, so this will do. Keep talking.
Okay, so we had to come up with a production plan. So thinking about so we had to think through what skills do we actually need. And that was an interesting thing because so often we think about producing people, producing this or producing that. And it's better, I found it more helpful to stand back and say, what skills do we need in this country and how do we produce them? What will we use to do this?
Keep talking.
No, I can't. It's the next slide. Excellent. Oh. No. There we go. I got it. That's it? That's where it starts. So I put together what I call just a production plan for building capacity for improvement in Scotland. And like everything at IHI, it has to have an aim. And then, so this was one person's attempt to make sense of things. So I started to think about what's the type of capacity we needed. What's the strategic need for that capacity? How many of them do we need? Or how much of that skill do we need? And what's the capability? What's the operational plan to get it offered? What's the timeline and the process owner to get it offered? So this was our first pass at it, but it's been pretty good for us, I have to say. So we started out with IAs. IAs, what did we need? So it was important to say, what was the strategic need? You can't go out and say, we need a bunch of improvement advisors. Well, why? What do they do? Who are they? Why do we need them? So you're going to have a very time-consuming and expensive program come to Scotland to offer. Expensive because you've got to take all those clinicians off the wards, right, out of practice for the day, for several days, and plus they've got a lot of work to do in between. So trying to think through how do we justify these people? Do we need them, and where do we need them, and how do we need them? And then what kind of expertise, what's the capability they bring? So again, what do we need them for? What are we going to use them for? And then we thought about senior leaders, okay? So what's the strategic need to have senior leaders involved in capability improvement for improvement, rather? What do we need to build the capacity and capability for improvement with leaders? So built that out. We have then we have a plan for how we work with senior leaders, and we actually started that from the beginning. And Jason and I are really the process owners for that. Non-executive development, middle manager development. How's the middle manager going? Not so good. That is one I think we have missed a trick with. And I would suggest if you're doing this, you don't want to do that. It's not too late to go back, but I tell you, it would have been easier doing it forward. A lot of the people involved in the program are middle managers, but there's plenty that aren't. And so you can have 3 units, general wards, doing great work, and if the division leader does not know why you're doing this, you hit your head up against that glass ceiling very quickly. So you've got to think about those folks and think about them earlier than we did. Part of it is it's such a mishmash. You can't get your arms around middle management. Who are they? What do they look like? Their titles are all over the place. And from one health board to the other, they're different. So it was so messy, we just said, well, we'll come back to it. And here we are, and it's still empty. So that's got to be worked on still. We're not walking away from it. We just got to rethink the strategy. So program managers, we had a strategy for. It was important to have an infection control practitioner strategy. How many of you are there any infection control practitioners in the room? Yeah. So you come at things in a very particular way. And I think in the past, I couldn't say for you, and I won't speak for everybody, but my experience has been there's a strong bias toward this is the policy, this is what we need to do, let me help you think about this, and you need to be held to account. But one of the problems was the staff couldn't do what they needed to do. They didn't know how. So you can write any policy you want. If the staff don't know how to do it, how many of you have guidelines? How's that going for you? Terrible. Terrible. Because you write it and put it out there on the desk, and then you say, then a miracle occurs. Well, of course it doesn't. So the same thing. We really needed to think about those are really important people. How do we bring them in, but how do we agree on an improvement philosophy rather than a hold to account philosophy? So, and that, as in any job, that ran from here to here, right? Everybody does their job a bit differently. But it's really important to bring them into the fold because they're such an important resource. And we really needed to think about agreeing on improvement, an improvement approach. I thought it was so important when we first began this work, before we did during the setup phase. We went and spent some time at Health Protection Scotland, and I got to say, we were so welcomed there. It was fantastic. We didn't expect we would be, to be honest, because we have quite a different approach. But we went in and they said, look, we both want the same thing. We want infections decrease. You want infections decrease. And we've been trying to do this thing, and we're not getting very far, and it's driving us crazy. Is there anything you can do to help us? They were just so wonderful. And we said, we think we can. And it's worked great because it was a real partnership. And it's really been helpful, them to us and us to them, I think, in achieving those objectives. So that's it. So if you were to come up with, I want you, if you wouldn't mind, just use this one page as a template. And folks coming in remotely, I'd ask you to do the same thing. if you spend a few minutes, either alone or with whoever you've come with, and think about, for what you're working on at whatever level, what would a production plan look like for you? What kind of capacity do you need? Why do you need them? How many do you think you need? What do they need to do? And do you have a plan for that? So if you'd spend a few moments thinking about that, and then we'll come back. We'll have some questions. So how about I give you 5 minutes?
Yep.
5 minutes, just as a start.
So, sorry, I didn't know you had added slides.
Well, it's production plan. You couldn't just talk to them.
No, I know.
Oh, yeah.
So I would have had I'd have had that one up if I'd known that was the right one.
I didn't know you had uploaded them. We never even talked about it. So when I uploaded my stuff.
So 2 days ago, I sent you an email that said, "This is the final one. Are you happy?" And
You did.
And I got no reply.
You did.
So
you did.
So I went to
And
the.
I would have said yes. Because then when I got, but 2 days ago, when I got to the production planning, so I was reviewing.
No, you're right. You're right.
I thought, what the heck?
No,
I
no,
didn't put it up here.
No, you're right.
No, that's not your fault. That's my fault. Because I thought I was uploading them. Of course you did. Well, how? So we ended up having 2 on here? It loaded 2. That's how we were able to get to it? Thank goodness. Well, I couldn't talk to it, but it wouldn't have made much sense.
So we haven't got much. We haven't got.
10 minutes. 5 minutes to do this and 5 minutes.
And then we'll.
Any brief questions?
Yeah. And you were meant to do short term. You were meant to.
I know I was.
You were meant to keep going.
I know I was.
So see these 2 slides.
Just we were meant to do the one.
Yeah, we're meant to do the
Yes.
cycle.
And I could not remember. I knew you were doing 2 or 3. And then I thought, well, it actually makes no sense. They're the same person.
It's fine. It's fine.
But mostly it's because I didn't.
She can hear us.
Just 2 more minutes. Sorry. Okay, I'm going to call you back together. I hope you, if you're interested in this, that you continue to work on something like this if it's useful to you. So I'd like to ask a question. Is this kind of laying out helpful? Does it seem like a helpful template? Raise your hand if it seems helpful. Okay, useful? Okay, good. I've never done it before. This was the first time I'd done it, so feedback's good. So questions, thoughts, concerns before we end? Hold on. You have to hold on for the mic. Very good.
Why don't you add patient safety and risk managers on your capacity needed?
Patient safety and risk. They're one person?
Yeah, I mean officers.
Yeah.
Risk
Yeah,
management officers.
We could, definitely. We didn't have a strategy for them, to be honest. So they're an important group. They're actually, they're integrated into a different structure that we have called, governance. And a lot of them are already in the program, so they don't call them that.
So the idea of the first column is for your context. So your first column will look different from our first column. And we will have stuff in it that you won't have, and you will have stuff in it that we don't have. So the idea is to contextualize the groupings, a bit like a driver diagram. So the contextualize the groupings that you require to teach or to engage or to enthuse in some way. It's not all teaching. Some of the executive stuff is about getting them excited or...
Yeah, so bringing in risk somehow in whatever form would be a good idea, yeah.
Hi, I just wanted to ask about the short space you did on productivity and efficiency. Are you setting up that same infrastructure for program managers in that same way in terms of training, etc.?
So not exactly the same way, but there's going to be steering groups for each of those elements, and then there is a different way into the boards, into the delivery system to deliver that productivity and efficiency. Now, the really intriguing thing, which we haven't really tested yet, is how to link those two worlds. Is how the quality and safety people who have learned in this world will be able to help with the productivity and efficiency. And we're not quite sure how to do that. We know how to do it at an executive level, but we're not quite sure how to do it at an operational level. Yes.
Yes, and
yes.
The people who do that, it's a group called IST, and they use improvement methodology, lean and improvement methodology very much. So philosophically, we're completely aligned. Yeah.
Carol, when you started showing the driver diagram at the beginning, you talked a lot about hearts and minds, but there wasn't really a specific driver on generating that social conscience, that social movement, the social marketing aspect, and to actually try and sort of create that swirl at the bottom end rather than the top end. And I'm wondering if there is, how is society involved, how are patients involved, how are the frontline caregivers, rather than being the receivers of education, maybe they should be demanding it. And then is there any work on health professions training so that when the next group enters, that they actually get it rather than needing to be trained?
So you've got to start somewhere. And starting with mobilizing patients when we've done such a poor job of it as a world is a lousy place to start, in my mind. It's a fabulous place to begin. You've got to have people who are receptive audience to have those patients there too. It's both. You can have patients demanding, but demanding what? I don't have the capability to do it. So you can demand of me all day long. I don't know what you're talking about. So it isn't just simply that. It's demanding from a system capable of producing. So it's very important. And some of our boards bring patients. But I'd say it's certainly, I would never say to you, boy, we've done a crackerjack job with that. But it does need to go there. It does need to go there. And the last one, I think you said something about that's the open school. So yes, we have do you know what the open school is? Yeah. We have open school chapters at every Scottish university. So nurses, docs, pharmacists, dentists, all health professionals, very active chapters in Scotland. In fact, they hosted the international meeting 2 years ago. So yeah, very active. Yeah.
I'm interested the extent...
This is Shona Cowan. Oh, Kathy. Oh, Kathy Green. Sorry. Where are you, Shona? Oh, there you are. Jeez, I'm looking right at you. Go ahead, Kathy.
I'm interested the extent to which you were thinking about push versus pull in designing this capacity building plan.
Well, I guess at the start, there's a little bit of both, isn't there? So there were lots of people who just banged the doors down, said more. And they're always at the top of the diffusion curve, right? They're the early adopters. And then as they became successful, others said, well, this looks like there's something to this. You just got to win them over. But the only way, so this is sort of a bit of our philosophy. You can act your way into believing or believe your way into acting. So if you ask people to believe their way into acting, you're going to spend a long time. So we're going to talk a lot. I'm going to try to convince you. But I will never convince a lot of them. So we try to get them to act, get them just far enough to try a test of change. And then they say, wow, that wasn't so painful and might even do something good. So if we can get them to act, even the skeptics, the smallest possible test, we can usually get them to believe. So I think that's really important.
So it's a good opportunity to advertise. We'll have one more question, and then we have to send you all off. But it's a good opportunity to advertise the fact that we published an article today in Health Affairs, which comes out today, about the Scottish Patient Safety Programme. And the reason I mention it is not to advertise it. It's to say it required Carol and I to reflect on what we've done. And the only way we can summarise what we've done is we ran a mandated Hearts and Minds collaborative. That's what we did. We organised a mandated, government-led Hearts and Minds collaborative. And only in hindsight can we see that's kind of what we did. So it was more than just Hearts and Minds. It was Hearts and Minds, but it was compulsory. You had to engage because we forced the boards to engage. Now, then, once we get them in the room, we then had to do the Hearts and Minds thing, and it would have all fallen apart if we hadn't been able to do the passion thing, and the enthusiasm, and the data, and the results, which have then driven further passion and enthusiasm as a result of that, as you all know. But there's something about mandating it in the beginning that caused the room to fill up. And I'm not sure the room would have filled up without that level of mandation at the beginning.
No way.
So one
if
last...
you had 10 years, maybe.
One last question.
Sure, thank you. Two very quick comments, no question. First, in March 2010, we started developing our own strategy in Afghanistan. And the first strategy that I read, the draft strategy, was the Scotland strategy that I have it on my computer. And it was excellent among 20-25 country strategy that I read. Thank you. That's a great strategy, and congratulations.
All right.
Yes, the second...
So how much did we say that would cost?
Yeah, did anyone ask us?
Oh, well, the next comment is about the cost. This framework is great. I found it a lovely, great framework. We are doing things here and there, but I think this will lead the way forward very well when we take it back to Afghanistan. The only thing that I would add here, for us, cost is also very important. We need to put something about the cost. How much would it cost for us? Thank you.
I think that's a crucial column. I think you're absolutely right. And cost in terms of bringing these people out of where they're working, and cash cost to provide the technical expertise that is required to teach it. I think you're right. I'm really sorry. There are people with hands up. If you want to come to the front and ask us questions, but there is a plenary, so it would be kind of disrespectful if we didn't at least offer you the chance to go to the to the plenary. So thank you very much for coming.
Thank you very much.